Today's session is going to cover a few topics on GI bleed. To be more specific, it's on going to be on variceal GI bleed, right? And some certain associated complications. We start like this. This is a John Doe, 54 years old male. You've got a medical history of chronic alcohol use disorder, liver cirrhosis secondary to hepatitis C, previous episodes of esophageal variceal bleeding. The current medications that this person is on is propranolol for portal hypertension, lactulose, and MBI, right?
Okay.
So the presenting complaints are, uh, this guy presents to the emergency department with severe fatigue, hematemesis, that is vomiting in the vomiting blood vomit, as well as melena. History of melena is there, black tarry stools, which started off earlier that day. He says that he's feeling dizzy and lightheaded, especially when he's standing. So then we look at the vital signs. The vital signs are BP of 88 by 54 mm of mercury, a heart rate of 115 beats per minute, temperature of 98.6. General appearance is pale, diaphoretic. This patient appears to be in distress. Abdomen is soft, mildly distended, no palpable masses. There is a hepatomegaly. Neurologically, the patient is alert, but slightly confused.
Okay.
So I am audible till here.
Okay, yes, it's working. Perfect.
So over the course of some time, next few minutes, what we are going to discuss is what is the diagnosis? One, what would you define as clinically significant bleeding? Thirdly, defining treatment failure for UGI bleed. Fourth would be what are the risk factors that can contribute to such a bleed? How to replace the blood products in an upper GI variceal bleed? What are the caveats for role of lab tests and FFP use? When do you give antibiotics? What are the pharmacological agents which are used for the same? When and which endoscopic interventions should be used? And a little bit about tips.
Okay.
So workup wise, hemoglobin is 7.8, which is low. Platelet count of 75,000 per microliter, again, which is consistent with chronic liver disease, which is low. INR of 2.1, which is prolonged, again consistent with coagulopathy of liver disease, and liver enzymes and bilirubin are elevated.
Okay.
So related terms that we need to understand is time zero is time of admission to a medical care facility. Clinically significant bleeding would be transfusion requirement of 2 units or more of blood or more within 24 hours of time zero with a systolic BP of less than 100, postural systolic change or variation in BP of more than 20 with a heart rate more than 100 beats per minute at the time zero. Acute variceal bleed is time interval from hospital admission to 120 hours till day 5. Then treatment failure would be any of the following criteria if they occur within 120 hours of time zero. Fresh hematemesis or more than 100 ml of fresh blood in the nasogastric aspirate, which is seen more than 2 hours after start of a specific drug or an endoscopic treatment. Patient has hypovolemic shock. A drop in hemoglobin of more than or equal to 3 grams per deciliter or 30 grams per liter within a 24-hour period. So all these things would be considered as treatment failures if these features are seen within 120 hours, that is within 5 days of time zero. And what is rebleeding? Rebleeding will describe clinically significant bleeding, which is seen more than or equal to 120 hours after the first hemorrhage, if hemostasis was achieved initially. I am clear till here?
Okay, yes.
Okay. So what are the predictive factors? These are the factors which actually predict that the bleed, it is more likely to be a massive variceal GI bleed. So varices at a location of distal esophagus, stomach and rectal sites. Now risk of variceal bleeding will actually correlate independently with the diameter or size of the varix. You can get red wale marks, cherry red spots, hematocystic spots, and diffuse erythema, which would be dubbed as characteristic endoscopic signs. You would look at severity of liver disease or child score and history of prior variceal bleed. The risk factors would also include early rebleeding for such as age more than 60 years, a concurrent kidney failure, and ascites. Variceal pressure, which is be categorized as more than or less than equal to 15.2 millimeter of mercury, because anything more than 15.2 millimeter of mercury, it is more likelihood for this for the varix to bleed. Now, general treatment principles for this patient would be: you closely monitor the airway, clinical status, vital signs, cardiac rhythm, urine output, and NG output. You maintain nil by mouth for all these patients. Get your two large bore IVs in, preferably size 16, but if not, anything in the range of size 16 to size 18. Supplemental oxygen, your goal oxygen saturation should be more than or equal to 94 patients. For those patients who do not have a coexistent COPD, you may have patients who may be smokers along with a variceal bleed. So for those patients, those are the only exceptions for which you are going to breach this 94% mark. Now, rapid bolus infusions of isotonic crystalloid, such as 500 to 1000 mils per bolus, you can use smaller boluses and lower total volumes for those patients who have got a coexistent compromised cardiac function. That is, in the sense, they may be having a heart failure, they may be having a poor ejection fraction, and they may be having a dilated cardiomyopathy. So, Jan, I
Yeah.
went ahead with the answers as well because this is supposed to be
Okay.
a mock session. How would you actually replace blood products in an upper GI variceal bleed?
Okay. You have to think how much blood loss there is. Maybe you can anticipate it. You can look at the hemoglobin. You can look at the lactate level. You can look at the base excess. And then you have to see, you can start with red blood packages, and then you have to see how much you have given. And sometimes, if you need, maybe you have to, it's a massive transfusion, then there are massive transfusion protocols. Maybe it's then you have to add also thrombocytes and maybe FFPs if you have so much erythrocytes.
So would you like to keep certain things in mind when you're going to give all the three blood products?
I think you have to check if you give blood, you have to check how is the adequate an increase in hemoglobin, or is it is acute bleeding? I think it's, and then I have to monitor the patient very maybe on a ICU ward like this, and you can measure the
Would you
blood
like to have
pressure.
definite therapeutic thresholds over which you would like to transfuse or not to transfuse?
Um, I think you have to look at the base access at the clinic, at the patient, and at the hemoglobin. If the hemoglobin is under 7, I think it's an acute indication to give red blood products. And maybe you can, I think it's dependent on the medical clinical situation of the patient, I would say. And if the patient is chronic, anemic, it's another situation than when it's an acute fall in hemoglobin. But I think if the is also cardiac compromise of the patient, then you can get an higher hemoglobin level threshold for transfusion. So I would say if it's also a cardiac risk patient, maybe the threshold should be 8 or 9 gram per deciliter hemoglobin, but the absolute indication is under 7 gram per deciliter IB.
Okay. What would you like to comment on the role of lab tests in terms of defining, your PTINRs, your APTTs, your would you like to do certain tests of thromboelastography or something of that sort?
It could help. I think it's point of care. Of course, in acute bleeding situations, there's something like Rotem. You can use something like this, and it's an patient and with hepatitis and liver cirrhosis. So it could be that there's also chronic derangement of the of lab tests. And I think it's a big role for this, yeah. But you have also look at the clinic of the patient, because it could be that there are also other factors. It could be a derangement of the hemostasis, but there's also a problem with the coagulopathy. So it's both, I think, in this patients. And they could help, of course, lab tests, but you have to also look at the clinic of a patient. And FFPs, I think it could also help FFPs, especially if you have
How many FFPs would you
massive
like to use?
transfusion. I think if you have a massive transfusion situation, you give like more than 5, 6, 7 red blood products, and you have also compromise in the blood pressure. So you see he's also volume dependent. You can see say maybe some clinical measures. You can use echocardiography, pulse pressure variation, and if you see you have massive volume loss, you can use FFPs. So in this patient, it's also an option, I think. Yeah. But you have to think. I would start with red blood products, and if you see it's not enough, the patient needs volume, you can use FFPs also.
Okay. Now, would you like to give antibiotics in this particular patient?
You have to think if it's a patient, you see, maybe it's an septic patient, then you can give antibiotics, but I would give antibiotics if there is no infection. You can see maybe some clinical parameters. You can
Such
measure
as,
lactate level. And but in this patient, maybe you can measure PCT, CRP, leukocytes, and if there is ascites, you can take some ascitics, see if there is a spontaneous bacterial peritonitis. Then of course you have to give antibiotics. But it also depends on the clinical situation in this patient. If they're getting septic, you think there is an infection, then you give antibiotics, but not standard.
okay. Uh, Tell me something. I mean, what antibiotics you like to use if you were given a choice that you have to use antibiotics?
You have to consider the infection pattern. It's mostly it's a gram negative pattern. So maybe you can give something like piperacillin plus tazobactam. You can give meropenem. It depends a little bit on your antibiotic pattern, but mostly I would start, if it's a septic patient, I would start with piperacillin, tazobactam, and then wait if you get maybe some blood samples or some ascites puncture. Then you have to check if it's adequate. But in this patient, then when it's septic patient, I would start with piperacillin, tazobactam at the first line. And then you have to see if you have to add something. But I think with piperacillin, tazobactam, you're on a good way for the first antibiotic.
Uh, what about controlling your GI variceal bleed? How would you do that?
You can say with beta blockade, propranolol in this patient, it's a good option. Then I think you can octreonate, something like this. You can add.
What are the drugs that you would like to use for the same?
I would say propranolol. It's a first line agent for this patient.
Can you repeat that? Yeah.
Propranolol. It's beta blockade. I think it's an option for this patient if it's bleeding. And of course, if you need to have to increase blood pressure, you can also use catecholamines, like this norepinephrine, something like this. If it's acute bleeding situation, and if you want blood pressure about 60, 65, something like this. maybe it's okay when it's active bleeding. You can use permissive hypotension, but I think the threshold should be 60 millimeter of mercury in this patient.
Would you like to do endoscopy for these patients?
I think you have to do this in this patient. If it's acute bleeding, then you have first stops the bleeding, something with Singstake and Blaker sondation, something like this. But you need, of course, endoscopic. You have to see where's the bleeding. Maybe you can, with endoscopic intervention, something like you can stop the bleeding. You can give some medication, some into the yeah, there are some, I don't know exactly the name for this, but there are some interventions, endoscopic, like endoscopic interventions, you can stop the bleeding with it. Yeah, and
So how would you stop the bleeding? What are the endoscopic interventions you're primarily looking at?
you can see at the varices, you can maybe you can clip the varices, something like this. There's also you can see where the bleeding is coming from. It's from the esophagus. It's coming from the stomach, and it's of course it's a medical intervention that you should look for it. Yeah? But you need a specialist for this, a gastroenterologic doctor, something, and you should take the patient on a ward, of course, that you can monitor the patient. Very, very careful for this. Yeah, but if it's not acute bleeding, I would start maybe in 30 minutes, 1 hour to endoscopic intervention for this patient.
When do you think you would like to use tips for a variceal bleed? Or when would you suggest a specialist to do tips in a variceal bleed?
The problem in TIPS is when the patient is in severe hepatic encephalopathy, then it's getting worse with it. But if there is a bleeding, a recidive bleeding, something like this, and you it's not able with endoscopic interventions, then you have to do a TIPS in a patient. Yeah, but you have to think, of course, and have in mind that if you get TIPS and you have a severe hepatic encephalopathy, then of course encephalopathy will getting worse. But if you cannot stop the bleeding, it's bleeding, and you have done everything, your pharmacological intervention, endoscopic intervention, and it does not work, then you can use a TIPS. But also for these tips, you need special care. You need a radiologic intervention room. So you also need the staff to do this. Yeah, but it's it's an option if you cannot stop the bleeding with endoscopic or pharmacological agent. And if you have rebleeding, something like this, so it's of course a good option. But we have to mind this.
Jan, we'll discuss all these questions in the debriefing part, right?
Yeah.
And I will go on to the second case vignette now.
Okay.
Right?
Okay.
So we go on to the second case vignette. Okay, this is visible?
It's visible.
So this is the second case. You've got a 54-year-old man with a long-standing history of alcohol use disorder and chronic hepatitis C infection. Now, this man was diagnosed with cirrhosis 2 years ago and has developed progressive liver dysfunction. His recent symptoms will include jaundice, fatigue, and abdominal swelling, which have worsened over the past 2 months. Now he's been having multiple episodes of ascites, which have been requiring paracentesis, and this man is currently on a low sodium diet and diuretics. You've got the vignette till here?
Okay, yes.
So current problems are, this guy presents with complaints of decreased urine output over the past 5 days, despite a good fluid intake. He feels increasingly weak dizzy and lightheaded whenever he was standing. He denies chest pain or shortness of breath, but does mention worsening abdominal discomfort. On examination, he is jaundiced and is visibly emaciated with prominent ascites and peripheral edema. His blood pressure at baseline is 90 by 60 mmHg, pulse rate of 96 beats per minute with mild orthostatic hypotension. Right?
Okay.
This is his workup. Serum creatinine of 2.4 milligrams per deciliter. Baseline was 1 milligram per deciliter 2 months ago. BUN, or blood urea nitrogen, of 46 milligram per deciliter. Serum sodium of 130 millimoles per liter. Serum potassium of 4 millimoles per liter. LFTs were done, which actually reveal an elevated bilirubin level, low albumin level, and prolonged INR, which is consistent with chronic liver disease. There is no significant proteinuria, hematuria, or casts. Abdominal ultrasound shows an irregularly shrunken liver with no evidence of obstruction, but it actually confirms that there is extensive ascites. Doppler ultrasound was done, which shows a patent hepatic and renal vasculature. You got the vignette by till now?
No, at the moment it's everything okay.
Should I repeat it?
I think I got it. It's okay, yeah.
So these are the questions.
The types.
So what are the types of hepatorenal syndrome and how do you diagnose the same?
I think there are two types of hepatorenal syndrome, type 1 and type 2. I have to think about. I think part 1 is an acute hepatic renal syndrome, and you have also a cirrhosis. And to diagnose the you have to see it's hepatic failure, ascites, plus impaired renal function, so elevated creatinine or low urine output. So I think the type 1 at the moment, I don't know really the differentiation. The cardinal features of hepatorenal syndrome, it's a combination of liver cirrhosis, impaired liver function, and plus acute renal failure. So this patient is in acute renal failure with an elevated creatinine, and I think it is ascites, hyponatremia. It's also a diagnostic workup, elevated creatinine, low urine output.
Anything else?
I don't know if it's also an infection or spontaneous bacterial peritonitis, but I think it's not a cardinal feature. I think it's elevated creatinine, low urine output, and ascites. And I think this is the cardinal features of hepatorenal syndrome.
Anything to do with urinary sediment?
Maybe I can also measure if there are some problems in the tubules of the nephrons. You can measure it, but I don't know exactly what's the threshold for this. If there is it could be maybe there are also a urine tract infection. It could also be a feature of hepatorenal syndrome. But I don't know if it's a cardinal feature at the moment.
What are the precipitating factors for hepatorenal syndrome?
It's liver cirrhosis, chronic liver cirrhosis. It could also maybe hepatitis patient. It's hepatitis B, C, something like this. It could also be a patient with hepatocellular carcinoma. So a patient which is developing liver cirrhosis in after an hepatocellular carcinoma.
I would I would rephrase my question. What
Okay,
do you think are factors which precipitate an episode of hepatorenal syndrome in a patient of chronic liver disease?
it could be if a patient is hypovolemic patient, maybe also a urine tract infection, a peritonitis, spontaneous bacterial peritonitis could also precipitating factor. Maybe also a big operation of a patient, everything which is destroying the status quo of the patient. So an infection, something like this, big operation, urine tract infection, something like this.
Anything else that you can think of?
Hypovolemia maybe could also be a factor. Cardiac decompensation could also be a factor.
So
Acute
how would you
liver
treat?
failure,
Yeah.
acute and chronic
How
liver
would you
failure.
how would you treat hepatorenal syndrome? If you know
These
that a
patients,
certain patient is having hepatorenal syndrome, what would be your line of treatment?
of course, you have to put this patient on a special ward because it's severely ill, this patient. And then you have to check, maybe you take probes from the ascites to see if there are infection in it. You have, I would, to this patient, I would maybe a central venous line, an arterial line. You have to check the sodium. It was 130, so it's also low sodium in this patient. So you have to monitor very closely the electrolytes, potassium, sodium. If it's acute renal failure and volume overload, or the potassium is increasing, then you have to maybe you need also dialysis for this patient. You have to check for the liver function. If it's an elevated acute liver failure, something like this, we have to. I would also talk to other special doctors, something like gastroenterologic, to see. Maybe you can do something like L-ornithine aspartate for the liver. It's acute liver failure, rifaximin, lactulose. Maybe these are options. But of course, this patient needs special treatment. Maybe you also need vasopressors for this patient. You have to check the volume status. Maybe this patient also needs albumin. It's also in risk for bleeding. This patient. So you have to see it's a severe ill patient. And first of all, I would take this patient on an ICU.
Is there any
And
role of peritoneal-venous shunts?
yeah, if it's severe ascites, severe maybe also there are severe liver cirrhosis, and then you can think about a shunt, yeah, for the if you cannot with conventional measures, conventional interventions, it's not possible, and there's so much ascites, and a patient is clinical worsening. Then you can also think about a shunt for this patient. Yeah, but also for this you need special units, special medical intervention teams for this. So it's not possible to do it in every hospital, I think. Yes, it's very special intervention shunt. Yeah, but you can think about
Okay.
this patient.
So
Yeah.
I would be going on to the next case vignette now.
Okay. Yeah.
So here you have John Doe, a 57-year-old man with a 10-year history of liver cirrhosis, secondary to chronic alcohol abuse, presents to the emergency department with abdominal pain, fever, and worsening confusion over the past 2 days. His wife reports that he has been more lethargic and has a reduced appetite, which is unusual for him. This is okay?
Okay, yeah.
So some more data on that. He has got a history of cirrhosis, which was diagnosed 10 years ago with multiple admissions for ascites management and occasional hepatic encephalopathy. He reports diffuse abdominal pain, but he cannot localize it, and it has been progressively worsening. Now, this patient has got fever with chills, and this patient has got confusion and disorientation, which is of new onset. There is no history of recent travel, antibiotic use, or surgical procedures. The patient is non-compliant with his medications, which actually includes spironolactone and furosemide. So, what do you think is this?
I think it's spontaneous bacterial peritonitis, I think, in this patient. It's
So, some more data. His examination findings. Temperature is 101.3 degrees Fahrenheit. BP of 100/60. Heart rate of 110 beats per minute. Respiratory rate of 22 beats per minute. And SpO2 of 94% on room air. This patient appears ill and lethargic. He has mild jaundice. Abdominal distension with positive shifting dullness indicating ascites. There is mild tenderness on palpation without rebound or guarding. Neurological examination wise, this patient is disoriented to time and place. There is an element of asterixis there, and there is a mild peripheral edema. Right?
Okay.
So when we look at initial labs, complete blood count, WBCs were elevated with a left shift. When we talk in terms of liver function tests, elevated AST, ALT, and bilirubin with decreased albumin. Renal function wise, elevated creatinine and serum electrolytes with mild hyponatremia. PT-INR are prolonged, which indicates a coagulopathy, probably secondary to liver. So, how to establish a diagnosis of spontaneous bacterial peritonitis?
For this, you have to take a probe from the ascites, and then you have to count the cells. I think the threshold is, I think it's 250 cells per millimeter cubic. I think it's a threshold. So if you have more than 250 cells, granulocytes especially, that's then you have diagnosis of spontaneous bacterial peritonitis. So, but you have to
Okay,
take
when
a
would you
probe.
like to give antibiotics for this patient?
I would this patient, he's fever, he's also an septic patient. I would start antibiotics in this patient. Yes, he's severely ill. I would start antibiotics in this patient, and I would start antibiotics early in such a patient. Maybe also before you have the diagnosis, if you see it's a septic patient, low blood pressure, maybe he's also elevated lactate, elevated CRP, leukocytes, maybe also PCT. But if you see it's a septic patient, I would start.
Just a minute. There's a lot of ambient noise. I'll just pause it a little bit and get a headphone. Just give me a minute.
You?
Okay, we can restart.
Okay.
Yeah. So when to give antibiotics?
Antibiotics, I would start in this patient. He's severely ill. He's in the beginning of septic. I would start immediately in this patient. If you see low blood pressure, elevated maybe CRP, PCT, elevated leukocytes, and so in this case, I would start immediately with antibiotics because the patient is going to sepsis.
Okay,
And
how would you how would you score for severity of liver disease in these patients? And do you have any specific scales for that?
In this patient, you can sepsis. There you can use maybe the SOFA score. Then there's also the Child-Pugh score for Child-Pugh score for this. You can see at the INR, ascites, if there is hepatic encephalopathy, if there are, I think also I think the thrombocytes are also
So,
in
what are
this.
the type of scores that you are aware about when we talk in terms of scoring severity in chronic liver disease?
You can also use, maybe you can use the MELD score. It's also a score. It's for maybe for liver transplantation. There are also King's College criteria, Clichy criteria. And for sepsis, you can use the SOFA score.
Now, if I were to have this patient who has a concurrent renal dysfunction to go along with it, how would I treat it?
You have to see, maybe it's a pre-renal failure because of volume deficit, because there is so much ascites. You can see if you can, maybe you can measure also the abdominal pressure. It could be abdominal compartment syndrome. So you have to check. Also, you can, if it's you can use dialysis if it's acute renal failure and you have absolute indications, something like a volume overload,
Would you
hyper.
prefer to use a simple dialysis, or would you prefer to use CRRT?
I think in this patient I would use a continuous renal replacement therapy because he's still in a low blood pressure. He's a septic patient, and if you use continuous CRT, it's more that you have more hemodynamic stability. So in this patient, I would use a continuous renal replacement therapy.
What is culture negative neutrocytic ascites?
Culture negative. I think if you take a probe from the ascites and you have, I see, I don't know exactly where the threshold is. Maybe it's under 250 or under 200 cells, then you call it negative neutrocytic ascites. But I don't know exactly the threshold for this. But if you cannot, it's under the threshold for diagnosis of spontaneous bacterial peritonitis. Then I think if you cannot see neutrophilic granulocytes, then you call it negative. But I don't know exactly. Sorry, there's exactly a measure threshold for this.
Right. I'll close the case clinic now and we'll go on to images. Let's go to this. So, what drug is this? Are you aware about this?
Okay, terlipressin. Okay.
So what is the mechanism of action? How does it act and where is it used?
Terlipressin, it's also an agent like vasopressin. You can use it in if you have a patient in severe septic shock, something like this, and you are maybe you have a threshold of 0.25 microgram per kilogram per minute nor epinephrine, and you cannot reach adequate blood pressure, then you can use terlipressin. You can also use it if you had a patient with maybe bleeding esophageal
Can you use it for all the bleeds, or would you like to use it for a variceal bleed only?
you can use it. I think it's you can use it. This is it's if you if beta blockade does not work and also in combination with propranolol, maybe you can use terlipressin. It's a good option, and
Are there any contraindications for its use? What are the indications and indications have been done? Contraindications for use?
I think it's a strong vasopressor, so it could be contraindications if you have maybe something like mesenterial ischemia. I wouldn't use this. It could also contraindication. I don't know if you have fresh myocardial infarction patient. Maybe I also would not use it because it's a vasopressor, and maybe the other I use it if there's acute
Okay.
bleeding. I
I will
don't
go
know.
on to the, I'll go on to the next one.
Okay.
What does this image show?
Is it? Okay, it's a portal vein, and then it's a stenting from the portal vein to the vena cava, I think. So it
So
could
what do you think
be
this is?
porto systemic porto vena cava shunt, I think this is.
So
And
what are the
it's
indications and contraindications?
the indication, it's maybe it's severe liver cirrhosis, and it could also be massive, maybe esophageal varices. It could be if there is massive ascites, could also be indication for this.
No issues. No issues. We'll discuss this during the briefing. Okay. Again, another drug. What do you think is this drug? And what are the indications for use in a chronic liver disease patient?
So taxim. I cannot read. Is it cefotaxime, something like this, or
Yeah, it is cefotaxime. It is cefotaxime.
cefotaxime sodium? Cefotaxime. I don't know. Is it I don't know if it's an antibiotic, something like this. Could be an antibiotic.
It is an antibiotic.
It says cephalosporin, maybe in my opinion. And I think it's class cefotaxime. Maybe it's a class 4 cephalosporin, and I can think you can use it in spontaneous bacterial peritonitis. It's a good gram-negative spectrum, in my opinion.
Okay. So what is this? Can you tell me the indications for use in a chronic liver disease patient?
I
What are the
think
prerequisites for use and what are the complications with use?
this thing's taken Blakemore sondage. I think you can use it in acute esophageal varices bleeding. And there are two balloons, in my opinion, one gastric balloon and one esophageal balloon. And if you start, I think you just inflate the gastric balloon, because it could also be that you get something like ischemic. You induce ischemic, esophageal ischemic, if you inflate it for a long time.
So what are the
So
complications once you
complications.
use it?
I think the complications are maybe ischemic complications, I think. And the necrotic, is esophageal necrotic, maybe something like this. Stomach could also be, if there are too much inflation pressure, there could also be some necrosis. And then maybe rebleeding through this necrosis. But the main problem, I think, is necrosis if you use this. But it's
We'll go on to the next.
it's for acute treatment for esophageal
So
varices.
what does this grade show and where is it? What is its significance?
I think this grade, it's for hepatic encephalopathy, and these are the stages, I think. Yeah, it's from 1 to 4. And it's also important for scoring systems, like I think for MELD score, for shield puck score. It's also important, and it's a score for hepatic encephalopathy, and you can treat hepatic encephalopathy maybe with something like rifaximin, lactulose, because it's high ammoniac is a problem in these patients.
Okay.
Yeah.
So What is this? What is this test?
Interpretation, value. Okay, I think it's a test to see the urea creatinine ratio, and you can differentiate the causes of acute renal failure for this.
So what happens in the hepatorenal syndrome with this particular test?
I think you can see if it's a hepatorenal failure, it's pre-renal failure or intra-renal failure or post-renal cause for this, and then you can differentiate the treatment, I think. If you need, maybe you need volume in a patient, maybe you need a renal replacement therapy, or you have maybe something like a stone in the ureter. It could also be. So
Okay, I'll go on to the next one.
Okay.
Among what are these category of drugs? What are and what are its indications in chronic liver disease? What are the contraindications and when you need to stop this?
I think these are the beta blockers, and you use for chronic liver disease. You use beta blockers, something like propranolol, something like sotalol. Maybe you can also use it, but I think propranolol is the first choice for it, because these beta blockers they don't are more on the splanchnic vessels, and you shouldn't use something like metoprolol or bisoprolol, because they are action on the cardiac system.
When would you like to stop beta blocker in a patient of CLD?
I would stop if you have severe bradycardia in a patient. Maybe also if you have a patient who is in septic shock, I would also stop beta blockade. I would also stop if you see if maybe you have septic cardiomyopathy, something like this. So I would also stop if you are using, maybe you are, is there as indication for inotropes, then I would stop beta blockade in a patient.
I'll go on to the next one. So what does this image show where it is used in a patient of chronic liver disease? And what are the complications and risks associated with this person?
I have to check for this. Is it? Or could it? Maybe it's. Is it a tips? Could be a tips. I think it is. It's in a tips because it's going to the from the hepatic vascular system to the vena cava. It's going to the vena cava superior.
Fine.
But it could,
We'll
it's
discuss this
a
more.
tips, I think. Yeah.
We'll discuss this more during the briefing. Okay. Now, what are these different scores used for, and how do they compare with each other in evaluating a liver disease?
I think these scores are used for prognosis in acute liver failure. The MELD score, it is, I think it's a mortality score. The Schild-Pox score, it's a score for liver cirrhosis. The Cliff-Sofa score, it's also a score for liver. I think you can use this for liver transplantation.
So, how are they different from each other?
I have to think about. I think the MELD score is a mortality score, in my opinion. And it's more for the 3 months mortality.
No worries.
Okay.
No worries. We'll discuss this more in detail. Till that
Okay.
point in time, we'll have time to revise these as well. Okay. So, what machine is this, and what are its indications for use in a chronic liver disease patient?
This dialysis machine, it's for continuous renal replacement therapy, and you use it if if you have a patient with chronic liver disease and acute renal failure. You can also use it in hepatorenal failure, and if you have absolute indications for renal replacement therapy, something like volume overload, acidosis. You can also use if you have high urea and also mental complications through this.
Okay. Fine. We'll go on to the next one. This is incidentally the last one. What does this image show, and when is this procedure done in a patient of chronic liver disease?
I think this is endoscopy image, and it's showing, I think it's esophageal varices, I think. And it's an intervention. It could be something like, is it something like a clipping, varices clipping, something like this, I think is shown. So it's an intervention for esophageal varices, is it? And
I'll put in a pointer here. Can you see this pointer here? What is this?
yes,
What do you think is this?
I think this is the varices, I think.
What is it?
I think it's or is it not? But I think there's a varices, the esophageal varices, and it's something. Is it something like
Are able to appreciate a band?
I don't know if there's a clip on the base of the varices.
Fine. This
It
would
looks
be
like
discussed
this.
further. So this is all for now, Jan. This is all for now. I didn't scare you, right? That's fine.
Okay, yeah. Thank you very much.